So welcome everyone on our Chrome Club webinar. Tonight we will discuss the Chrome Guided Smile records and how to perfect those records. Our goal is to provide you the information which will help to improve the accuracy of the Chrome parts, and as a result the Chrome surgery. It will help also with the cooperation between the clinician and dental laboratory staff, and also it will improve the patient experience with the patients who decided for the treatment with the Chrome GuidedSMILE product. So discussion for tonight's topics, discussion of the topics for tonight's webinar. I've prepared for you 4 points. The first point will cover the theoretical part. We'll discuss all scenarios for dentate cases and edentulous cases. The second point will cover most common mistakes to avoid during the record taking for Chrome GuidedSMILE protocol. I prepared for you over 17 videos and some screenshots of real-life cases which we received in the laboratory with the most common mistakes. On the third point, we will talk about the JC try-in and the role of the JC try-in in the Chrome GuidedSMILE workflow. And at the end, I would like to invite you to the CAD design world, where I would like to present you the case which we completed with Dr. Shane Patel from Quality Dental Group. This case was really record sensitive. That was double arch, fully digital workflow. Upper arch we completed with the grammatary workflow, and the lower case was Chrome GuidedSMILE arch. Let's start with the record overview and how to capture the right records. As a first record, we'll discuss the pictures and the photographs we should receive for Chrome GuidedSMILE workflow. Ideally, we should receive between the 6 to 8 photographs. First 3, picture number 1, 2, and 3 are the photos of the full face, patient full face with the natural smile, exaggerated smile, and profile smile. Picture number 1, we are using mostly for our smile design in the CAD software. Picture number 2, exaggerated photograph, we are using to assess our transition line of between the future prosthesis and gingiva. Picture number 3 will help us with assessment of the video. And photographs 4, 5, and 6 are the retracted photographs in the full occlusion, which help us with the assessment of the bite and the occlusion. And here I would like to discuss additional 2 photographs. Those ones are helpful for edentulous patients. As you can see on the left, we've got the picture with the natural relaxed smile, and on the picture from the right, we've got the exaggerated smiles, and those pictures are really, really important in the edentulous workflow, because those pictures would help us with the assessment of the transition line. So as you can imagine, if we received only the pictures with the denture in the mouth, the flange from the denture would cover the soft gingiva, and we wouldn't be able to assess correctly the transition line. So that's why it's very, very crucial to provide us the set of the pictures with the denture in the mouth, which we'll use for our smile design. And it's also important to provide us the pictures without the denture for the transitional line assessment. Here I prepared for you example of the good photographs of the patient for dentate cases. I sourced those pictures from the Exocad website. As you can see, the patient is standing, the head is straight. We've got really good quality of the image around the teeth. The lens of the camera or mobile phone is orientated opposing the tip nose. To keep the head straight, we can always use the ear tips as our references point. From other sides, I prepared for you also the photographs which are not the greatest, as not the best record of the patient photograph. We can't really work with the blurred photographs. If we have a dentureless patient, as I've mentioned, it's important to provide us the pictures with the denture in the mouth and without the denture. And we strongly encourage to do the patient smile photograph before the impressions, mostly because if the impression material will stay on the teeth during the photograph record, that would create a problem for us with the alignment of the STL into the photograph, as we are using the teeth as our reference points for the alignment. From the helpful guidelines, have the patient wear an existing prosthesis in the photo. Photograph the patient standing up, looking directly at the camera. Capture photo before taking impressions to keep the lips and the teeth clean. Now let's discuss the master cast and models. Good master cast should cover the full palate, should capture most of or all surrounding labial and lingual tissues, and should be free of the hole, skips, voids, or bubbles. And why we need to have the good record of the palate or surrounding tissues. So let's imagine that for the dentate cases, we are manufacturing our pin guide, which delivers the fixation base and the rest of stackable components. And the pin guide is fitting over the teeth and surrounding tissues like a palate. So it's really, really crucial to provide us good record. In addition, some of our customers are ordering backup dentures. So as you can imagine, we need to have good record of the palate. From other helpful guidelines, we can understand that it's challenging to capture all vestibule with iOS scanner. But please, if you could ask you to capture as much of the palate and surrounding tissue as possible. And if you notice any distortion, please retake the impression or the scan. Please don't send to us the records with the distortion, and don't wait for our assessment, because that potentially might cause the delay, because we might, in worst case scenario, we might back to you and ask to repeat the records. Let's discuss the bite registration. Good bite registration should be captured full occlusion or centric bite, taken with the patient in a closed bite in natural occlusion. If the patient has prosthesis, have the patient wear their prosthesis to stabilize the bite. That's really important because the prosthesis would create additional vertical stops. From the helpful guidelines, use enough material to capture the occlusion, but not too much as to open the bite. If the patient is missing posterior stops, we recommend the bite blocks or a GC-Trine. A GC-Trine appliance will stabilize the bite and help to establish the occlusion. Now let's go through the CBCT scans, and we will cover the dentate scenario. We need to capture both arches. If we are doing double arch cases, the CBCT should be taken with the patient in the open bite, taken with the patient's denture out of the mouth if the patient is wearing any partial dentures. From the helpful tips, have the patient bite on a cotton roll or the bite fork to keep the bite open. We can also play the cotton rolls between the cheeks and the teeth for a better image. If the field of view only allows us to capture one arch, Then we need to receive a second record with the second arch, and this is applicable for the dual arches. And last tip is to export the DICOM files. We call it DICOM slices, but those ones are DCM files. And let's export them from the CBCT into a patient folder. So we should receive the one folder, zipped folder, with the DCM files. The folder should contain between 200 and 400, sometimes even more, of individual DCM files, and all should be zipped into the one folder. Now we will discuss the edentulous cases, and let's start with the first record of the scan of the denture and how to prepare the denture for edentulous cases. So first point is really important. We need to be sure that the denture is fully seated during the in situ scan. There shouldn't be any rock or any gaps. And to prepare the denture for the scan of the denture alone and in situ scan, we advise to use the 6 markers, which should be placed randomly. We advise to place those markers 3 on the flange from the buccal and lingual side and 3 from the palatal side. If the patient has good denture, prepare, as I've mentioned, 6 markers or gutta-perca markers randomly on the pink area of the labial flanges. If the patient has poor denture, either fabricate new denture or perform the hard reline. From the hard reline, we can advise to use the blue mousse on the intaglio of the denture to stabilize the fit of the denture. Unfortunately, we can accept the soft relines, and the reason of that is the soft reline on the CBCT record is visible as a void, and unfortunately, we wouldn't be able to confirm the correct fit of the denture. And if the patient doesn't have the dentures, then you should consider to fabricate the new dentures, or as an alternative, we can provide you the GC Trine, and we can also use the GC Trine as a dual scan appliance. And I've prepared for you 2 pictures. On the picture from the right side, we can see not the greatest record, mainly because we are seeing the black void. We call it air gaps. So this indicates for us that the denture is not fully seated during the in situ record. From other side, on the left, we can see the very good record where the denture is fully seated during the in situ scan, and we can't see any black gaps between the soft tissue and intaglio of the denture. So how to prepare the dual scan protocol? For the edentulous cases, we should really receive 2 CBCT records. First one, we call it record in situ, so is a scan of the denture in mouth. Is very important to perform this scan in occlusion, not separated, with the markers in place. And the second scan is a scan of the denture alone, resting on the foam, not on the plastic. Why we don't advise to take the records of the denture alone on the plastic? Mainly the occlusal surfaces, which are used later for sitting and pinning the pin guide during the surgery, would melt with the plastic object. So the quality of the occlusal surfaces won't be good enough. And very important point to remember, very important point to remember, the position of the markers on the both scans should be the same. So in the in situ scan and the denture alone scan, the position markers should be the same. And that's very important because we are using those markers as our reference points. And after the segmentation of the scan of the denture alone, So after exporting the STL of the denture, we try to stitch, and we are stitching and the denture into the in situ scan, and we use those markers as our reference points for accurate alignment. We don't need to receive the scan of the patient alone without the denture. Again, please export the DICOM files into the one zipped folder, which should contain, as I mentioned before, between 200, 400, sometimes even more individual DCM files or DICOM slices. And if you are having difficulties with the accurate scan of the denture alone, we are more than happy to help, and we can also do this record in-house at Quaris 3D. As alternative, you can also use the dedicated child mode or study mode as a setting in your CBCT scanner to improve the quality of this record. What record do I need? We are now on the topic record overview. So at the beginning, I would like to mention that all of the details and records are covered on our website. So our website will have all information regarding the records needed for each scenario. If you could visit our website, quaris3d.com, and visit the page of CHROME GuidedSMILE patient records, then you could find all of the helpful information about the records needed for CHROME GuidedSMILE protocols. Right now, we will discuss each scenario for single patients. So single dentate arch with the opposing dentate arch, we should receive all photographs previously discussed. Impressions or the scans, iOS scans, should be good quality, especially surgical arch. We should receive good quality bite registration, and CBCT scan should be taken in the open position without the denture in the mouth. Single dentate arch with the opposing edentulous arch, again, all sets of the photographs required. Surgical arch, capture all land areas. Non-surgical arch, capture the scan of the denture. We also required good bite registration or bite scan. CBCT scan should be taken in the open position, and denture should be out of the mouth. Single edentulous case. Again, we need to receive from you all set of scans, and in this scenario, we also would like to ask for additional 2 pictures discussed previously. So first is a picture of the patient without the denture in the relaxed smile. The second picture is a picture of the patient without the denture with exaggerated smile. And as I've mentioned before, we use those pictures for assessment of the transition line of the future prosthesis. Capture all land areas, non-surgical arch. We would need to receive the bite registration or bite scan. And here we will follow the dual scan protocol. So we would need to receive 2 scans from you. The first one is scan in situ, so scan of the denture in the mouth, in occlusion, not separated, with the markers in place. And the second scan is a scan of the denture alone, resting on the foam, not plastic, with the same, exactly the same position of the markers. That's really, really important. Single edentulous arch with the opposing edentulous arch. Again, all photographs are required, plus 2 photographs of the patient without the denture, with the relaxed smile and exaggerated smile. From the master cast, we really need to receive from you the scan of the denture. We need to receive the good record of the bite registration or bite scan. And here again, we would follow the dual scan protocol. So scan of the denture in the mouth, in occlusion, not separated, with the scan marker in place. And as a second record, we would need to have scan of the denture alone, on the foam, not plastic, with the same position of the markers. Now let's discuss the dual arch patients and each scenario for dual arch patients, double dentate arches. Again, we would need to receive all records of the photographs, the good set of the photographs. In this case, we would have 2 surgical arches, so it's very, very important to provide us the excellent records about the surgical arches, impressions, or IOS scans. We would need to receive the good bite registration, and we should perform the CBCT scan of the both arches in the open position without any prosthesis in the mouth. Double edentulous arches. Again, the set of the pictures required plus 2 photographs of the patient without the denture, with the natural smile and exaggerated smile for the transition line assessment. We don't really need to have any impressions because we will receive the CBCT record of the dentures alone, so we will be able to extract the STLs from those scans, print them, and create the putty models for the articulation and for the model surgery simulation. But we still would need to have a good record of the bite registration, and here we'll perform the dual scan protocol. So we will scan the dentures in the mouth, in occlusion, not separated, with the markers in place, and then we will do 2 separate scans of the denture alone, resting on the foam, not plastic. I will repeat again with exactly the same position of the markers. Dentate and edentulous arches, dentate arch with the opposing edentulous arch, all set of the photographs required. We would need to have the record of captured all land areas for dentate arch only, good record of the bite registration. And here we'll perform the dual scan appliance, so scan the denture in the mouth, in occlusion, not separated, and scan the denture alone, resting on the foam, not on the plastic. Now let's go to the second point, which will cover the most common mistakes to avoid in taking the records for CHROME GuidedSMILE workflows. And we will start with IOS scans and the models. I've prepared for you 4 main points, which should cover the most common errors for IOS scans and the models. Let's start with the first scenario, where we have 2 STLs not in the same coordinates, and we are missing at the same time the bite scan or putty bite, or the bite record is insufficient. How we handle this type of the problems? So we try to then print 2 separate models, and then we will perform, as we call in the laboratory, hand articulation. We use the photograph to establish the occlusion. Very often we are able to do it, but there are some more challenging occlusions where unfortunately we need to back to you and reconfirm the bite or ask for additional records like a putty bite. The second point will cover the intersection in occlusion between the upper and the lower jaw. This is common error, creates the problem with the digital model creation with the articulation pins. So in this scenario, we also try to find the solution, and we try to print 2 separate models. And again, with the photographs, we try to establish the occlusion. In the more challenging occlusions, we are forced to contact you and ask you for help with reconfirming the bite, or we would ask you for additional record like a putty bite. The third error is the most critical and most serious error, because here we will have a scenario where the digital scan has the artifacts like double imaging, And that's really critical, especially for surgical arches, because we are manufacturing the pin guide, which will sit over the teeth and surrounding tissues. So as you can imagine, we can accept any record of the scans with the artifacts or double imaging. And in this case scenario, unfortunately, we are forced to ask you to repeat the record. From the analog standard plaster models, we should avoid any holes, skips, voids, or bubbles. As a helpful tip, with the digital scan records, we encourage to provide us a standard patty bite as an extra record in case of mentioned above issues. So the patty bite might be excellent backup in CHROME GuidedSMILE cases, especially when we have the problem from the point number 1 and number 2. If we would receive the extra record as a PVS standard patty bite, we have additional record to establish the occlusion, and that would help us to establish the occlusion, and we wouldn't contact you to ask for additional records or to reconfirm the occlusion. We have more data to work with to establish correct occlusion. Next slide would show you example of the double imaging on the STL record. That's the lower surgical arch, and we can see the double imaging on the tooth 3.3 and 3.4. Another slide will show us the maxillary case where we can see two problems. The first problems are the double imaging on the occlusal surfaces. Another problem is the artifacts. And now if we have the artifacts separated from the 3D object, then we are able to clean it up, the STL, and proceed with the case. But the problem will appear when the artifact is stitched into the STL. Another example of maxillary case where we can see the double imaging on the occlusal surfaces. The next slide will show us the case with the multiple problems, because we've got the intersection in between the upper and the lower jaw. And in addition, the scan is incomplete with holes, and unfortunately, we are unable to accept those records. The next screenshot will show us the intersection between the upper and the lower jaw. And at the same time, we were missing the bite registration or bite scan. In this scenario, we try to print the models separately, hand articulated, and use the photographs to establish the occlusion. Another example of the intersection between the upper and the lower jaw. And here I prepared for you the short clip, which will show the STL with two issues. The first one is an intersection in the bite. The second is a small artifact around the tooth 1.3. How we handle with this case, we cleaned up the STL from the artifact. We've printed two separate models, and we advise our client to manufacture the GC trying to reconfirm the bite. Common mistakes to avoid, bite registration. So common issues with the bite registration. So the bite is only captured in a narrow occlusion. There is used too much material which will separate the bite. Bite is not captured with the teeth in natural occlusion. How to avoid those issues? So we always can capture the full occlusion. The bite should be taken with the patient in a closed natural occlusion. In natural occlusion, should be taken with the patient prosthesis in the mouth if applicable. And if the patient is missing posterior stops, we recommend to use the bite blocks or GC Trine. GC Trine appliance will stabilize the bite and help establish a correct occlusion. Now we will cover the common mistakes to avoid for CBCT records for dentate cases. And the first error is applicable for edentulous cases and dentate cases. So we really need to receive from you the one zipped folder with the DICOM slices inside. Very often we receive the zipped folder which contains the installer for the CBCT viewer, where we can only work with the DICOM slices. So it's very important to remember to provide us the correct record. And on the screen, you can see correctly zipped folder. So the folder contains individual DCM slices. Double imaging in the CBCT record for dentate cases, where we can see the double image around the bone area. This creates a problem with the precise implant plan. I prepared for you very interesting case. That's a lower CHROME case, very challenging shape of the bone, hourglass shape of the bone. And in addition, we discovered double imaging around the bone area. And unfortunately, we had to ask our clinician to repeat the record. Let's cover the next slide. Wrong field of view. This is quite common inaccuracy. The bone is cut off on the surgical arch. It's impossible to plant the implants if the surgical arch has incomplete bone CBCT. I've prepared for you the graphic from our partner laboratory, Rowe Dental in the United States, where you can see correct field of view for maxillary cases and mandibular cases. So maxillary case field of view should be from sinus to the lower occlusal plane. And for the mandibular cases, the correct field of view should cover area from the chin to the upper occlusal plane. I've prepared for you the short clip, which will show you the example of the wrong field of view. That's a lower CHROME case, dentate case. You can see we are missing the data around the anterior area of the lower jaw. Unfortunately, we were unable to proceed with the case, and we had to ask our client to repeat the process. Now we will cover another problem, which is a CBCT taken in the closed bite. And as a clarification, if we receive the case of the CBCT where the patient has unnatural teeth, then very often we are able to provide the correct stitching of our digitized model or iOS scan. But the problem appears when we have closed bite record and the patient has restorations, metal framed restorations. So the metal artifacts and metal noise create for us the problem with the correct stitching. As you can see on the video, we've got the patient the closed bite with the metal framed restoration. And unfortunately, in this case, we were unable to proceed with the case because we couldn't achieve good alignment of the STL over the CBCT record. Now we will go to the next stage, which will cover the common mistakes to avoid for the CBCT edentulous cases. The first error which I would like to discuss with you is a missing record. So we need to remember that for edentulous cases, we really need to receive two CBCT records. The first one is a record of the denture in the mouth in occlusion with the markers in place. We call it scan of the denture in situ. The second record is a scan of the denture alone, placed on the foam or cotton roll, not on the plastic. If we are missing one of those records, unfortunately, that would create the delays, and we can't proceed with the case until we receive the full set of the CBCT scans. Now we will cover the problem of the different position of the markers on the both scans. As I mentioned before, we are using the markers as our reference points for accurate stitching of the scan of the denture alone into the in situ scan. And as you can see on the short clip, the position of the markers on the denture was different than in situ scan, and we couldn't achieve the correct stitching, and unfortunately we couldn't proceed with the case. Wrong field of view. Here we will cover any cutoff on the in situ scan or denture alone scan. We need to remember that is very critical when we have cutoff of the occlusal surfaces of around the markers on both scans, so we should avoid those errors. In addition, if we will do the scan of the denture on the plastic object, as I've mentioned, the occlusal surfaces would melt with the plastic objects, and quality is not good enough. And as we discussed before, we use the denture as a direct copy of our future pin guide, and we load the pin guide during the surgery in the full occlusion. So we need to have good quality of the record. That's why we are asking for scan on the cotton roll or foam. And another problem appears when we have the cut off around the bone or around the markers. That creates the problem with the implant planning or with the correct stitching. Let me show you the examples. So on the very left, we've got the record of the denture alone, scan of the denture alone, placed on the plastic object, and as you can see, occlusal surfaces melted with the object, and the record is not good enough. We couldn't proceed with the record. We had to ask for repeat the record. From the right side, we've got the wrong field of view, where we can see nice record of the markers, but unfortunately we are missing the bone area. That was the lower arch, and unfortunately we also couldn't proceed with the case because we didn't have enough data to do proper implant planning. Air gaps. Air gaps is one of the most important errors to avoid, and air gaps error happen when the record is taken in the open bite, the patient denture doesn't fit correctly and needs reline before the CBCT record, the patient has large posterior gaps on opposing, and the scan cannot be taken in stable occlusion. I've prepared for you the video where I would like to explain why it's very critical to avoid the air gaps. So we do our implant planning and our CHROME parts design on in situ record, and we need to replicate the position of the denture from in situ record on the day on the surgery. So we use the scan of the denture as a direct copy of our pin guide, And as you know, the pin guide will deliver the fixation base. Fixation base is a foundation for our stackable components. And if you would imagine that we will have some air gaps between the soft tissue and intaglio of the denture in the in situ record, there are very small chances that you would be able to replicate exactly the same position on the day of the surgery. Let me show you the short video. We've got really nice record of the denture with the markers, no air gaps around. And as you can see, our pin guide is a direct copy of the denture, and the pin guide would deliver the fixation base. Fixation base is a foundation for our osteotomy. We see the implant plans. So if we would like to perform very accurate surgery, we need to replicate the situation from in situ scan during the surgery. And that's why we should avoid any air gaps, and we should be sure that this record doesn't have any issues with the air gaps. Next clip would show you the example of the air gaps. So we've got really nice record of the denture alone with the random placement of the markers. Unfortunately, the record has been taken with the fork in the open position, and as you can see, we see multiple black voids, air gaps around between the soft tissue and the intaglio of the denture. We had to ask our client to repeat the record, and as an additional precaution, we asked to reline the denture before the next in situ scan. So let's go to the summary. We must remember the denture will be used as a pin guide. The position of the pin guide in the mouth must be the same as a denture during the taking record stage. Any deviation will create inaccuracy during the surgery. Inaccurate fit of the pin guide is equal to inaccurate position of the fixation base and osteotomy, and that's create potential inaccuracy in the future temporary bridge and implant position. If the patient denture is worn, damaged, we advise to use the JC Trine as a dual scan appliance. If the patient has large posterior gaps on the antagonist arch, 2 separate patty bites or printed lower GC Trine are advised during in situ record to stabilize the fit of the denture. Now I would like to share with you the rule which we follow at Quarries: measure twice, cut once. And additional sentence which makes sense to me: checking records before submission is never a waste of the time, but potentially a huge time saver in the long run. Now I would like to show you how I do the CBCT denture segmentation. How I segment the scan of the denture alone, and I create the STL, which we will later stitch to in situ scan. So as you can see on the screen, we've got the scan of the denture alone. We are going to the segmentation mode. We play with the thresholds. We click segment the bone, so software will create the 3D object. And at the next stage, we can edit the 3D object, smooth it, and STL is ready to export and stitching stage into the in situ scan. Now I would like to present you the correct edentulous case. In my opinion, is one of the best records I've ever seen for edentulous cases. Here we have additional difficulties because on the opposing dentition we have posterior gaps, but dentists use separate putty bites to stabilize the feet. We've got really nice record of the denture alone, good placement of the markers, and as you can see, beautiful stitching, no air gaps. In addition, doctor provides us also 360 IOS of the denture, and after assessment of the quality of occlusal surfaces, we decided to actually use this 360 scan for designing our pin guide. So what we've done, we've stitched together the 360 IOS scan of the denture together with scan of the denture alone CBCT record. And now I would like to show you how I check the CBCT records for dentate cases. That's the case from Dr. Jerry Skeffington. We can see beautiful dentate case, clear image, no double imaging around the bone. So what we do, we import our surgical arch IOS scan, and we use the assisted AI option in RealGuide for the stitching. And as you can see, we've got very, very precise record, and we are more than happy to proceed with the case. The next clip would show you how we check the photographs and STL records. Again, that's a FP1 case from Dr. Jerry Skeffington. So Dr. Skeffington provides us 4 pictures, 2 pictures retracted to confirm the occlusion, 1 pictures in occlusion from the center view, and 1 picture of the full face, patient full face, all of them excellent quality. In addition, doctor provides us 2 STLs and physical putty bite registration, and of course, CBCT record. So as you can see, the quality of the image is outstanding. We didn't have any issue with the smile design because the quality of the image was really good. We've got STL of the opposing and beautiful STL record of the surgical arch. Now we will discuss the role of the GC trying in the CHROME GuidedSMILE workflow. So we can use the GC trying mostly in the 3 scenario in the CHROME GuidedSMILE workflow. The first scenario is when we would like to reconfirm the bite. We are unsure about the bite or occlusion is challenging. Then we advise to manufacture the GC trying. So as a reminder, the GC trying is a partial denture, and we send the device to the dentist, and the dentist take the new bite registration to reconfirm the bite. The second scenario is when we play with the video, when we receive the case with the collapsed bite, and we need to open the video. In the CHROME GuidedSMILE workflow, we are comfortable to open the bite in articulator without the manufacturing of the GC trying up to the 4 millimeters. Everything what is above, we need to manufacture the GC trying and check the video in mouth. If there are any changes needed, the dentist always can adjust the GC trying to re-establish the video. And the third scenario is when we have edentulous cases and the patient has a poor denture with the not greatest fit, or occlusal surfaces are worn, or the patient is missing occlusal surfaces, then we can manufacture the GC Trine, which can be used as a dual scan appliance for edentulous cases. I would like to show you the short clip of the case from Dr. Mervyn Macaulay. That's a double arch, as you can see on the screen, the patient with the collapse bite. How we perform with the case, we've decided to design the GC Trine on the both arches. As you can see on the screen, that's the original situation with the collapse bite. After consultation with clinician and with James, we decided to open the bite 10 millimeters. And we've designed the GC Trine for the lower posterior gaps and for the incisal edges. And on the upper, we designed the GC Trine to cover the palatal area. And why we decided to cover the incisal edges on the lower and palatal area on the upper on both GC Trines, the reason is that we wanted to create as many vertical stops as possible. So after the design, we print the devices and we send them to the doctor. Doctor is checking them in the mouth, assess the VDO. If necessary, adjust the VDO, take the new bite registration with the GC Trine appliances, and send back to us the record. And then we are happy to proceed with the model articulation stage. And now we are approaching to the last point of my presentation, where I would like to show you the real life case. As I've mentioned at the beginning, that's a very record sensitive case completed with Dr. Shane Patel, fully digital workflow, upper arch completed with the grammatary workflow, and the lower arch was a CHROME GuidedSMILE. So we start with the discussion with the doctor about the expectation of the patient. In this case, the patient wasn't happy about the position of the teeth. She wanted to move them up and hide the pink area and the necks. And let's see the overview of the records received from the doctor. So we received the physical optisplint luted in the mouth. We've created the model and we digitize it. We also received the bite registration. We received a separate scan of the lower arch, which has been used for the design of the CHROME GuidedSMILE parts. We also received the upper gingiva record with the healing cups, and it's worth to mention that those healing cups can be used as a reference point for stitching the optisplint against the soft tissue. In addition, doctor provides us the 360 scan of existing bridge with the markers screwed into the prosthesis. And those markers are exactly the same shape of the what the analog from the digital library. So those markers are really nice reference point for the alignment of the optisplint against the existing prosthesis. And as a last record, we received the existing bridge in situ with the soft tissue. So this scan would help us with the correct alignment of the soft tissue. How we approach the case. So we've decided to take on board all expectations of the patient, and we decided to start with the design of the wax-ups for upper and lower arch. And we think that was the very good starting point for reconstruction, the upper arch with the grammatary workflow and for the lower CHROME workflow. So the next video would show you all data in place, and I would like to bring your attention into the quality of the pictures of the picture and how important the good quality and good sharpness of the picture around the teeth is, and how big role it plays for the stitching of the STL into the picture. So we can see now the existing prosthesis together with the gingiva. Now picture nicely stitched into the STL. Existing prosthesis denture, existing prosthesis gingiva and antagonist. And now we have our upper and the lower wax up in place. And because the upper arch has been restored with the grammatary workflow, so the implants are placed already. I created the generic visualization meshes to show me the position of the implants. And also because of the implant positions, we decided with the doctor to design the upper wax up only with the 1 premolar and 1 molar. And that's mainly for the strength of the temporary prosthesis. So again, we see the wax ups with the photograph. And wax up stage is completed, and we are ready to go to the next stages. So the next stage would be a design of the upper grammatary case, upper grammatary arch. So we implemented the digitized model with the OptiSplint. We use our digital library and we mesh the library to the OptiSplint. And as you will see, we've got now the digital analogs, which are the same shape what the markers from the 360 scan. And that's how we stitch together the position of the OptiSplint with the existing prosthesis. Now we've implemented the in situ scan with the gingiva. And as I've mentioned before, this scan would help us to position correctly the gingiva scan. Pre-op with the wax up previously completed. New bite in situ scan. So it's worth to mention that in this project, our opposing will be the new lower wax up. Screw channels. And merged new bridge. So the next stage was to manufacture the model surgery. So we work with this case a bit different way than the standard CHROME cases. We didn't manufacture any models up front. We worked purely from the dentist record, from the dentist bite scan and all STLs provided. And we complete the design of the upper grammatory, and we had to manufacture the models for the model surgery, because for every single CHROME case, we do the simulation of the surgery in-house. So I had to provide to my colleagues some models which they can use for articulation. So as you can see now, I've implemented the wax up of the upper jaw, and it's worth to mention that in this scenario, the upper wax up would be our opposing, because now we will restore the lower arch. And now we can see on the screen the models ready for printing with the articulation pins. And we are approaching to the last stage of the implant planning and designing the CHROME parts and temporary prosthesis for the lower. So on the screen, we can see our wax up and planes, reduction plane, which is our bone reduction plane. We've got the transitional plane, which represents the thickness of the tissue. So is 3 millimeters above the reduction plane. And we can see the occlusal plane. Implants are already planned. We see the upper grammatory as our opposing. And now we can see CHROME GuidedSMILE, stackable components, temporary prosthesis, carrier guide, fixation base. And that's a final result of the upper and the lower arches. It's worth to mention that the doctor fitted the upper arch on the day of the surgery of the lower CHROME. And we think that's a very good base for confirming the occlusion and any aesthetic changes before the final restoration.